What's most important about improving quality? Well, probably actually clinical engagement is somewhere close to the top of the list. As an organisation, we're always committed to finding the best, most innovative people, not necessarily the best people who are doing the best work out there, but the people who are aspiring to do the best work out there. Improving quality of care, particularly improving outcomes for patients, is exceptionally difficult. The bottom line is, do patients get better?
How do we really focus on outcomes and where we're going to invest and disinvest, but hang on to the cultural change, because where you bring clinicians together to start small, it can actually grow into something that's significant.
I wonder if we ought to throw the word outcome out. It has language, this language is interesting. Subliminally, I suddenly realise it feels finite, as if there's an end point to it. Whereas actually, the health system is continuous. Well, there is one finite thing, a bit like tax, the other thing you get in life.
I think what the projects have shown this afternoon is something that we maybe have lost also in the health service, is that we're not only caring for people, but that the projects also care about people. And I think that's one of the things that is happening within the health service, with all the focus on outcomes, focus on audit, focus on measurement. We actually have lost that relational side.
Focusing on outcomes was a big P political response to being the opposite of targets. Targets were seen as a bad thing. Targets got in the way. There's lots of unintended consequences. But the opposite of focusing on targets is focusing on outcomes. And if the moment you say that, yes, of course we should focus on outcomes, the difficulty was not defining what outcomes meant.
I had a discussion with our Director of Finance, and he hadn't clocked that actually commissioning palliative care in nursing homes or in residential homes at no cost benefit was a huge improvement in value.
And the palliative care work, I think, actually did start the end-of-life work with targets. And I was only reviewing ours locally yesterday, and we've hit our target of choice of death for patients and carers. Now, targets or sort of focus on things can get an energy behind something.
The really, really important point this afternoon has been, when it was flagged up, the difference between what patients wanted and what the clinicians thought the patients wanted. And that is so critical.
In a cash-strapped NHS that's coming our way, of course, the free resource that's staring you in the face every day is the patient. We employ a nurse artist who runs an art and asthma course for primary school kids. And what you get is fantastic art at the end of a 10-week course, but most importantly, a kid, 10-year-old, coming in and saying to me, "Sam, my peak flow's gone down 50, I need to step up in my treatment, please prescribe me this."
I looked up the word engagement, and I found what it comes from is a French term, engager, which means to pledge. And it therefore carries the force of quite a strong commitment.
We have to have motivated, well-researched, evidence-based staff, but they've got to be caring. The patient needs us. They need to know where to go for the right care at the right time. That's not an easy journey, so communications and direction and signposting is absolutely crucial.
You know, on the one hand, we talk about quality improvement as if it's kind of like it is a technique, whereas in fact, I don't think it is that. I get from our project, I think quality improvement is about relationships.
Milton Keynes summed this up rather well when they said, quality improvement is not just an activity, it's a habit.
That resonates with what I was trying to say about it being maybe more habitual and straightforward, and something that is part of routine everyday activity rather than an incredibly difficult and elaborate thing that's dropped in from on high.
And in fact, when you get people really engaging in improving the way they meet the needs of their patients, then it's something you start to feel quite comfortable with, because it's actually very much a heart-driven sort of thing. It's not about how can we pluck a concept, it's about how can we start to help people change the way they are.
I think it was Aristotle who said that excellence was not a state of being, but a habit of doing. So I don't think he had QI in mind.
I'm pretty convinced that the vast majority of clinicians in the health service, whatever sector, whatever profession, actually want to do a good job. But they're really, really struggling. I think there really are tensions there. And one of the most important areas, I think, for research and understanding is what stops really good people being as good as they can be.
Quality improvement's not an add-on, and I think moving forward in tough climate is how do we get the headspace for clinicians to stand back and think, how can we do things differently?
And as a commissioner, I'm game, yes, I've got to do all the acute sector stuff and all the other things we've got to do, but I want to follow people's passions too, and I want to be able to stimulate that.
Well, there's a wonderful series of articles by Frank Davidoff, and he writes about the difference between evangelists and snails. And evangelists are the optimists. Snails are the kind of academics, if I want to stereotype them. Snails are the people who say, but hold on, wait, does it really make a difference in whatever way you want to measure how it makes a difference? The reality is that in order to improve care for patients, which is why we're here, we need both kinds of people. And indeed, ideally, we want to bring those two worlds together. And I think that the voice of the skeptics is weak and I think insufficiently heard. There is this fundamental question about why improving care for patients in a substantive and sustained way is so difficult, and it is difficult. And I think it's because in order to improve care in the way that we'd like to, we need to get this kind of balance between the things that we do, the interventions, the way that we do them, the implementation, and the context, the environment within which we do them. In order to get improvement right, we can't carry on working in the same health system or in the same way. We need to have a system redesign, and we've spoken quite a lot about that. But actually we need a bit more than that. We need what you might call a kind of mindset redesign as well.